Welcome everybody this afternoon. Thanks for still hanging in here. It's been a long but a great day here at ISPS-US. It's my pleasure to introduce our next two speakers. We're going to talk about the Maastricht World Survey on antipsychotic drug withdrawal. We have Rachel Flanigan, who is a doctoral candidate in economics. She has lived experience of psychosis and is the co-founder of the Mountain Hearing Voices group and has facilitated over 150 hearing voices meetings. And she's going to be speaking along with Will Hall, who's also a PhD candidate at the Maastricht University and a psychiatric survivor activist. He authored the Harm Reduction Guide to Coming Off Psychiatric Drugs and the book Outside Mental Health. You can also learn more about him on his website at www.willhall.net. So without further ado, I introduce the two of you. If you have, if anybody has any questions, they can put them in the chat, or later on we'll be opening up to raise your hand for questions. Thanks very much. Bye-bye.
Wonderful. Thank you, everybody. Thanks, Jess and Anastasia and the ASL interpreters. And I really appreciate all the organizers of ISPS, especially all the folks with lived experience. And I'm also really honored to be co-presenting today with my colleague, Rachel Flanigan, who has both expertise in the Hearing Voices movement, as well as expertise as an economist working with statistics and surveys. So Rachel, do you want to say hi before we get started?
Sure. Yeah, it's great to be here and to have a discussion about this work. So yeah, thanks everyone for having us.
Yeah, and I especially want to thank all of the many thousands of survey respondents, people who took the survey and made this work possible. So I'm going to go through this relatively quickly, and we're going to be making this collection of slides available to people afterwards. So our email addresses are there. You can contact us as well. And so let's get started. And we will have some time for Q&A at the end. I'm going to be presenting part of the slides, and then Rachel will be presenting, and then I'll be presenting a little bit more, and then we'll also wrap it up and come together with the Q&A. So here we go. All right, everybody can see the slides and everything. You can hear me okay, right?
Looks great, and you sound great.
Okay, great, thank you. So again, I want to thank and acknowledge everybody who's been involved. This is probably not everyone. My study committee, feedback, translators, as well as the design of the survey was actually a result in part of crowdsourcing. So we had people from the US and Germany primarily giving us recommendations and ideas of how we should do the survey. So I want to thank everybody who's been involved. The study partners are Maastricht University, the International Institute for Psychiatric Drug Withdrawal, which I strongly encourage people to find out more about their work. And we also have collaborators in Brazil with the, I will not pronounce it, I don't know Portuguese, but Fiocruz. It's a health public policy institute in Brazil. And we have a number of respondents from Brazil, so I very much appreciate their being study partners. The overview of the survey, it's an anonymous web survey. We have international recruitment. There's about 167 questions about the experience of antipsychotic drug withdrawal and about who and how. And it takes about 30 minutes to complete. If you just want to take a look at the survey questions, there's that link there, the bit.ly link. And also the recruitment is still open. We're having rolling import of the data. So if you or someone you know would like to take the survey, it's at antipsychoticwithdrawalsurvey.com. There's a typo in the link there, but it's antipsychoticwithdrawalsurvey.com. The inclusion criteria, who are eligible to be respondents, you have to be 18 years or older at the time of taking the survey. You've taken antipsychotics, and if people are not familiar, that's drugs like Geodon, Risperdal, Zyprexa, Stelazine, Haldol, and you have tried to withdraw, or you have withdrawn from those drug. So people who attempted as well as succeeded, although attempt and succeed those are kind of general terms. We're going to be getting more into detail about how we broke down the respondents into different categories. The recruitment began in November 3 years ago. Wow, it's been a long haul. The responses, we have about 6,000 responses. We're working with the precedent analysis of about 3,500. That means there's about 2,000 pending import. A lot of those are null responses. So we're expecting the survey at this point to be between 4,000, 4,500 people or so. And like I said, the recruitment is ongoing. This link does not have a typo in it. The demographics, mostly female, which is actually consistent with other studies in terms of the prevalence of anti-psychotic drug prescriptions by gender. The age, we have a very diverse spread, 4 18-year-olds, 1 82-year-old, and then a real mix in between. The income, mostly 29,000 a year or less. That is adjusted by different country differences. Thank you, Rachel, for your work doing that. And education, again, a good spread, 46% are high school to bachelor's equivalent, 17% only have a high school equivalent or less. Disability, we have 25% of the respondents receiving a disability income for both psychiatric and physical conditions. 20% reported ever being homeless in more than 50 countries. So we consider that the demographics are fairly broad and representative. Continuing with the demographics in terms of people's psychiatric backgrounds, 81% reported taking more than one psychiatric drug at a time. 79% had been inpatient. It's important to keep in mind that 21% had not been inpatient. About 50% reported a diagnosis with a psychotic disorder. About 50% have not. Also important to keep in mind. The duration of antipsychotic use, 83% reported using antipsychotics more than 9 months total. That does not necessarily mean continuous months, but more than 9 months total. And about 49% reported suicidal feelings. So these demographics are important because we want to demonstrate that we have a broad sample in order to make our external validation to the actual population as a whole of people taking antipsychotics has statistical significance. So we broke out the respondents to 3 outcome groups. So people who came off of all antipsychotics and off all other psych meds was 38.5%. They came off just antipsychotics and also taking other psych meds. That can be anything from a so-called mood stabilizer, lithium or Depakote, to intermittent use of a benzodiazepine or the use of an antidepressant. So if we want to look at the number of people who were off antipsychotics, including those who continue to take other psych meds and including those who take no psych meds, we have about 58%. And then the rest are still on antipsychotics. Some of them are just on antipsychotics. Some of them are also taking other psychiatric meds. Importantly, a significant portion of those who are still on did reduce their antipsychotic use. So even though they tried and did not come off completely, they still reduced, often very significantly, their antipsychotics use. The question we want to zero in on this presentation is a question that we formulated and I think is on everyone's mind. We are still working on it. But what factors contribute to the likelihood of successful withdrawal based on these 3 different groups, or specifically actually the 2 groups, the AB group versus the still on group. So what factors contribute to the likelihood of successful withdrawal? And now my colleague Rachel is going to take it away and talk about what exactly a factor analysis is. And Rachel, just tell me when you'd like me to advance the slide.
Okay, well, there we are. So I'm going to talk a little bit about the some of the statistical directions that we're going with a research study using this survey. So like Will said, this is a huge survey with lots of questions, hundreds of questions in the survey. And so we can analyze individual questions and see some interesting things about this population. But I came into the study to help bring it all together and do some mathematical statistical analysis that really uses all the data and all the questions in this study. So the first thing we're doing is we're doing a statistical technique called factor analysis, and this is something that's a really big like statistical stalwart of big survey data, and is also used a lot in psychology. Probably people have heard of the big 5 personality traits in psychology, and that was all those were all narrowed down through factor analysis. So what is this we're doing? We're starting from the perspective that, okay, lots of people take these medications and then they attempt to withdraw. So if they attempt to withdraw, you know, there's something in the trade-off that's not working for people. The medication isn't doing what they wanted it to do for them, or something else like the side effects are just not making it worth it. So now what we want to look at is some people in the survey, everyone in the survey wants to withdraw. Some people do, some people don't. We want to look at the people who were successful at withdrawing compared to the people who didn't complete their withdrawal, and look at what are the underlying concepts that really supported withdrawal for the people who did manage to withdraw and then stay off of medication for a while. So the way we do that is we make a hypothesis. We listed out all of the concepts that we think underlie being able to have a successful withdrawal. That can be information, support, preparation, lifestyle changes, your socioeconomic situation, all the concepts that we think could contribute to someone having a successful withdrawal attempt or having more difficulty in withdrawal. So we have this list of concepts. Then we take our hundreds of survey questions and we group them under each concept. So for each concept, we have a whole array of questions that we hope got at that question in the survey. So then for each concept, we can make an index of that concept from the survey questions and rate or scale each respondent on that concept. Then we can take our concepts or our factors and put them into a multivariable regression on withdrawal, which is this mathematical statistical way of, you know, comparing the variance and the effect and significance of all these concepts, and that narrows down for us, you know, which of these hypothesized factors actually were key and significantly important to withdrawal, and which ones are not so important. So that's the big overview of the whole research plan, and I don't want in this venue to really get into the details of the statistics unless there are questions about that in the question period. Just because I know I know not everyone here is coming from a technical, quantitative research background. But that's kind of the overview. And I also want to say that this big analysis with this huge survey is a work in progress, and that's where we're going with it. So what I want to show you today is our hypothesized factors, and then dig into the questions and variables that are inside a few of those factors so that you get an idea of that. And then we're going to present some more what we think are interesting results from the study, because this is still a work in progress. And let's go to the next slide. And so I'm just gonna go over the,
And just to add to that, so both Rachel and I, we come from a background in the patient movement, the recovery movement, the hearing voices movement. And so one of the things that we hear very strongly coming from the medical scientific establishment is that there's one factor that would predict whether you can withdraw. And that is if you're no longer so-called sick. And so we wanted to test that and say, well, actually, maybe there are other ways of looking at this other than the disease model. And we did look at the severity and the kind of diagnosis, but we looked at other things like support or your attitude towards the treatment that you're getting. And so a lot of in the background is us saying, well, the survivor movement, the recovery movement has learned a lot of things about actually what helps people to withdraw from antipsychotics. It's very different from the messages we're getting from the medical establishment. Let's see if we can test this scientifically using, in a sense, the master's tools to dismantle the master's house. At least that's our possible hypothesis, and we're going to see whether that actually follows from the data.
Okay, so like Will said, from our experience, and we have a few sources of experience. So both of us have withdrawn from antipsychotic medications personally, though, you know, a sample size of 2 isn't significant, but we have that experience. But we both also have worked in the movement with many people who have withdrawn. So we have that experience of personally knowing many people who have been through this and having their input in this research as well. And these are, so we came up with 18 factors that we're hypothesizing influence someone's ability to withdraw. And what we really don't want to say here that there's anyone who can't withdraw. We have people in the survey who were on antipsychotic medications for over 20 years and still successfully withdrew. We have people who've been hospitalized multiple times and still successfully withdrew. You're going to see later we have lots of people reporting that they still experience psychosis, but they still withdrew. So we don't want to say here at all that there's groups that can withdraw and groups that can't, but instead we're saying that there are conditions in someone's life that make it easier for them to withdraw or more difficult for them to withdraw, so that people who want to withdraw can be aware of that and work with it. So our hypotheses here, we have a little plus if we think that that increasing on that scale would help support withdrawal, and we have a minus if we think increasing on that scale is going to make withdrawal more difficult for someone. So here are the factors that we're hypothesizing are important to withdrawal. We have severity of emotional distress, severity of side effects, severity of withdrawal effects, and it's Sometimes it can be difficult to disentangle side effects and withdrawal effects, especially when you're in the middle of it. But we are really observing those as separate concepts. Then we have degree of physical health, degree of class and economic privilege, degree of exposure to psychiatric treatment. Next slide. Degree of agreement with medical understanding, degree of compliance to medical authority, the use of coping tools, lifestyle changes to use coping tools, lifestyle changes to prepare for withdrawal, degree of previous drug withdrawal experience, degree of previous withdrawal from other substances. This is when people have experience withdrawing from alcohol or opioids or other things that might give them knowledge that can support medication withdrawal as well. And next slide. And then we have degree of flexibility in the approach as you go along, the degree of coercion the person has experienced. We're advocating for people to have agency and free choice and understanding over what substances they want to use or not, but not everyone has that choice at all times in their life. A degree of caution around the method, degree of supportive information given by professionals, the degree of helpful support that someone received during withdrawal, and the degree of childhood exposure that someone had to the mental health system. Okay, I'm ready for the next slide. All right, so I'm going to dig deeper into 3 of these concepts that we were interested in presenting today and sort of show how we're bringing them together in the analysis. So the first one we thought people would be interested to see something from is the degree of preparation for withdrawal. Lifestyle changes people made in preparation to withdrawal, their degree of planning. And the survey question's super simple. What preparations did you make for coming off? Check all that apply. And then we have 41 different preparation methods that people could choose. These are used independently or in combination. On average, people were using a little over 5 of the preparation methods. And people who were successful in their withdrawal were a little higher. On average, they were using about 6 preparation methods. Though, there's always a quantity versus quality of method question. About 18% of people only used 1 preparation method, and about 16% of people who successfully completed withdrawal only used 1 preparation method. You can also see there were people who withdrew using no preparation methods. 19% of people withdrew basically with no preparation and just did it anyway. Okay, we're ready for the next slide. So on the next slide, what we're showing is we want to learn from people who successfully completed their withdrawal and maintained their withdrawal. So this is narrowing our population down to a subgroup of people who completed withdrawal from all psychiatric medications and have remained in withdrawal for over 3 years. So these are people who, these are not people who, withdrew in the last couple months and we don't really So we can't really know what their outcome will be. These are people who decided to withdraw, they withdrew, and now they've been medication free for over 3 years, which now includes me as of last month. I'm celebrating that.
Congratulations.
Yeah. So what we're doing here is we ranked the top 10 preparation methods that were used by this group who successfully withdrew, and some of them might seem obvious, and some of them might be a little surprising. We have creating a dose reduction schedule, reducing stress, looking at food and nutrition, looking at herbs and supplements, using meditation or mindfulness, changing social relationships, such as ending a friendship or distancing from family that were unsupportive. And this is a huge part of withdrawal and sobriety outside of the concept of withdrawing from psychiatric medications. And then I want to go back up to number 2, because I think maybe the second method was a bit surprising. I informed my doctor or prescriber, and they didn't support my decision, but I went ahead anyway. So this came up really high in the ranking as a successful preparation method. And this really gets to some other important concepts here of both having flexibility, but also having the attitude of knowing what you want for yourself and what's right for yourself. And even though the doctor didn't support what you wanted to do, knowing what was right for you and doing it anyway. And that links us to the next factor on the next slide, which is factor 8, the degree of compliance to medical authority. That concept shows up again here. And in fact, 19% of our respondents said that they informed their prescriber. They didn't get support with that, but they still went ahead and did it anyway. And in addition to that group, you can see we also have a really large group that kept their withdrawal decisions secret, and that's for a variety of reasons, but that's another way that we're measuring compliance. Again, for the compliance factor, we have a lot of survey questions going into this factor, but we're looking at people's attitude toward following themselves on one end of the scale and their own knowing, and just following medical authority on the other end of the scale. And it's also important to point out, at the other end of the scale, we have another 4% of people who said it wasn't their choice to withdraw. A doctor withdrew them, without their input. And I think it's important to acknowledge that group's there too. Okay, next slide.
And just to add that being withdrawn by a doctor's decision, that was actually my experience. So interesting side note. And also I wanted to say that this factor is extremely significant because when we started to do the work around the harm reduction guide to coming off psychiatric drugs, having coming off medication groups, doing workshops and trainings and educating, I often heard the message, Will, you should always tell people, only try and withdraw with your doctor's approval. And I knew this from all the people we talked to, that was just not making any sense. It wasn't true. And so we went against it, but there wasn't a lot of data. And so the data that's coming in is actually supporting this idea that no, getting your doctor's approval is not a precondition or a causal factor in successfully coming off of psychiatric drugs, antipsychotics, much less the whole question of autonomy, decision-making, choice, self-determination, and freedom. But even from the outcome standpoint, it's not supported by the research.
I lied to my doctor. I told my doctor that I told my private psychiatrist that I was going to switch to a psychiatrist at my university health center because it was less expensive. And then I just never went to the university health center. Okay. And factor one. So I think this is a factor that's really important for us to have. It's something big in people's minds. Are people able to successfully withdraw because they're less distressed than people who stay on? And we don't really have a standardized measure of distress. So it was really important to us to very carefully look at all the survey questions and make a really comprehensive index of distress over a lifetime that people are reporting through various questions. So this factor is an index of distress, and it pulls together information from 15 different survey questions. There's a list of the concepts we're looking at here to help define distress. We have current extreme states, self-report of current ongoing psychosis in the past 6 months. We have current diagnosis, past diagnosis, hospitalization history, a lot of medication history if people are on multiple classes of medication, if they were trying to withdraw from multiple types of medications at once, if they're still taking medication, if they have a suicide attempt, if they have a history of suicidal feelings, if they currently have recent suicidal feelings, age of onset of what would be called psychotic symptoms, and a really great concept too that we're asking about is if people think they could cope with their symptoms before they took the medication. We also have trauma history and trauma rating. It's important that it really ended up being important that people rated their trauma in this because we have almost 80% of our population reporting trauma history, so there's really not much variation there.
Well, Rachel, just a quick time check. So you're 23 minutes in on your segment.
Okay. Well, one more slide and I can be done in like 1 minute. Okay, so we want to show. So this is just showing the distribution of the severity of distress index that we made. So you see a lot of people at one end. Those are people who are in the lowest distress bin, and then after that, we do have a pretty big range of respondents along the whole distress scale that we made. You can see the first line, the first big line in the middle of the distribution there at 6. The average reported distress was 6. We also did this. We also did this only with people who reported a psychosis diagnosis. So with people who only report a psychosis diagnosis, we have the same pattern. The average distress moves a little higher from a 6 to an 8, and we do lose that low distress group on the end. And yeah, we're really excited to put all 18 of these factors together, statistically, some of them are going to end up being combined or dropping out or not being that significant. We're right now we're in the middle of trying to get large-scale grant funding to keep going with this and put it all together. And okay, now we'll present some more results, and we'll take some questions.
Yeah, so if you have any large-scale grant funding you want to get, please send us an email. Okay, so closely related to what we were just talking about, this is a chart saying how many people are experiencing currently something that might be seen as a symptom of psychosis. And as you can see, it's quite high. It's 42%, and then it's broken down without a big gap. There's a 5% gap of the people who are on antipsychotics actually reporting more currently experiencing psychotic symptoms, which is consistent with what we hear a lot about in our work, that actually the meds don't necessarily treat the root of the problem, but they might make things a bit more manageable in some ways. So I'm just going to go through some of these quickly just so we can get to the Q&A, because I know a lot of people have questions. Some of the additional findings that we have come up with. So again, like Rachel was saying, we have a wide representation of respondents in all withdrawal outcomes. So basically, there's no type of person that we would say you can't withdraw. Like everyone from all kinds of different backgrounds, different configurations, length of time on, et cetera, was represented in all the different outcomes. So half of our respondents had taken antipsychotics for at least 5 years. So we're not studying a group of people who are only on for a brief period of time. And we had a significant number of people who had been on antipsychotics for more than 20 years total, not necessarily continuously, but total more than 20 years. And 39% of those who responded to the survey came off of all antipsychotics. This is a very hopeful message and consistent with what we've seen in the survivor movement. A big question we often have is like, well, maybe it's about people being educated, or maybe it's about people being employed. And we didn't find any correlation with your likelihood to succeed withdrawing based on either educational level or employment. Some of the other findings, this is a very strong finding. The longer that you're on antipsychotics, it strongly correlated with greater difficulty and less likely to succeed. And those are two somewhat distinct concepts, because someone could succeed withdrawing but have a harder time getting there. And so we break that down, but it's actually the length of time on antipsychotics is actually predictive of both. So more lasting negative effects, remaining on, rating the withdrawal harder, more severe withdrawal effects, all correlated with longer time. However, being on a longer time of antipsychotics did not necessarily correlate with greater likelihood of being hospitalized when you come off, which was interesting, because once people do come off, they often have a fear, well, am I going to be hospitalized? And we're not seeing, at least in the aggregate, which is an important thing to keep in mind, these are aggregate figures, we're not seeing that to be true in the aggregate. So we created this meme, which is a dilemma that a lot of people go through. Well, should I go through worse withdrawal, or should I go slower but have longer side effects and be on the drug longer? So do I go faster and the withdrawal is worse, or do I go slower and the withdrawal is maybe easier, but I'm on the drug for longer, so I have those side effects? And we're hoping that some of the granular analysis that we're going to do is going to help people to make that decision, but we do not have a conclusive data pointing that one is necessarily better than the other at this point.
We have applied for a grant to specifically look at this trade-off.
Yeah, exactly. So Thank you for reminding us about that. So
Yeah.
physical health, wow, of the people who tried to come off, this is all the different outcome groups, 82% reported their health is the same, better, or much better from trying to come off, and 57% reported their physical health is better or much better. Very strong result here. I'm sorry, I'm trying to get what's going on. Why am I not able? There we go. Okay. So here's some other withdrawal group outcomes. The age of first hospitalization did not correlate with a greater likely to be completely off, or less likely to be completely off. Greater agreement with your diagnosis did correlate with a less likelihood to be off, less success. So more past attempts did actually slightly correlate with less likelihood to be completely off, but there wasn't a strong, well, you've tried many times in the past, therefore it's very unlikely that you're going to be able to come off. There was only a slight correlation there, which is a very strong result from the data. Being on many medications simultaneously, polypharmacy at some point in your history did not correlate with a higher or lesser likelihood of coming off. Your past hospitalization did correlate with less likelihood to be completely off. We're not sure exactly what that means, but there was a correlation there. And being able to cope with your symptoms before you took medications did correlate with greater likelihood of being completely off. So which again points to the importance of public education and the community understanding how to be able to cope with these experiences. Let's see, whoops. So this is one of the most important findings from my perspective and from Rachel's perspective, is that we ask people, okay, you have to decide, do you want to try or do you want to not try? And often people are making that decision from the standpoint of like, I don't know what's going to happen. Am I going to regret this? So we ask people, well, are you glad you tried? Overwhelmingly, 92% of all respondents said yes, that they were glad that they tried. This is a very surprising result. It's not something that I anticipated at all. And actually, if you look at how hard it was, and you look at the length of time that people were on, there was no or very weak correlation. In other words, when people had a difficult time coming off, they did not necessarily find that they were more likely to regret having tried. So that's the presentation. We want to open it up to questions and discussion at this point. Please feel free to contact us. I have my email and my phone number there. Rachel has her email. We also, the data collection is ongoing. It's not as much of a push as when we launched the survey, but people participating now will be significant. So please, if you know people or you want to share it or you have not taken it yourself and you meet the inclusion criteria, go ahead and take it. We are sending out updates about this work to our email list, so you can join there. And there's also a sign up at antipsychoticwithdrawalsurvey.com. And then, as always, I have information, Rachel has information about the withdrawal process. You're welcome to contact us. You can also check out my website. You can also read the harm reduction guide to coming off psychiatric drugs.